Good afternoon. This is Dr. Pierre Kory. I'm the Chief of the Critical Care Service as well as the Medical Director of the Trauma and Life Support Center here at the University of Wisconsin in Madison, Wisconsin. I'm happy to be here today to talk about, well, really anything related to ultrasound, but in particular the detection of lower extremity deep vein thrombosis, a really important application that I've found very useful over the years, especially in the ICU. Today, obviously, this is just a general overview of a basic ultrasound examination. It's not a complete course of training, but I think you're going to learn a lot and make sure that this is not the only component of your training, but I think there's a number of things that you can take from today and apply at the bedside. So briefly, today, what we're going to do is I'd like to go over just how prevalent really and how much we need to be on the lookout for lower extremity DVTs in the ICU. And then we're going to go over really just how we're doing that in modern times. Largely we rely on ultrasound, and in particular one modality of ultrasound, that of compression ultrasound. And I'm going to go through some of the other ways in which we have done it and why we're largely doing it with ultrasound, as well as how well we do it as clinicians. And there's a fair amount of literature showing that we can do it. And in particular, that we're going to end up discussing just exactly how to do it and how to do it well. Obviously doing it well would require a lot of practice, but this would be at least a start and hopefully a refinement to the technique in those who are already doing it. I will also include a number of examples. So here we go. The culprit. Obviously, you know, blood flow through the veins, the valves create a little bit of turbulence. And in our sick patients with a little stasis or hypercoagulability, right, from Virchow's triad, this is largely where the thrombus originate. Some form of injury as well as stasis and hypercoagulability, you're starting to deal with the problem of thrombus, right? And so the RBCs and fibrin advance and they start to form mature clot, which can interrupt flow. And the thrombi typically are attached at the wall, and then unfortunately they can dislodge, float freely in the bloodstream and cause a lot of problems upstream, in particular that of pulmonary embolism, which we all know and dread and fear in our ICU patients. Here is an example, right, of the dreaded thrombus. This case in particular, this is an internal jugular thrombus, and again just supports the utility of ultrasound. And this for me is an excellent application, which is just surveilling or looking at the vein before you insert a catheter. Knowing that this is here tells you you need to avoid this site, maybe try the other side or some other site, because starting to manipulate or violate this vein either with a needle or a catheter could cause more problems than you're looking for, as well as be unsuccessful. So just a quick look at the site where you're going to put in a catheter sometimes can reveal rather unsuspected findings. And as you can see here, very easily recognizable echogenic material within a vein, which you know shouldn't be there, and that's consistent with thrombus. You know, as we go on today, I want to make sure that what you take away is a really good knowledge of the anatomy of the lower extremity. That's largely what we're going to focus on, and it's very important, I think, to know exactly where the veins are coming in, knowing that the branch points, where they're most commonly occur, are the thrombi, are at branch points. And so knowledge of the anatomy, especially on ultrasound, is very important in order to gain competence and expertise. So let's go over the anatomy as it looks like on ultrasound, because it's much different than on the cartoon diagram. But here, in this view, you see the common femoral vein and the common femoral artery, right? This would be high up, just distal to the inguinal ligament. And here's a nice compression, right, of the common femoral vein and the adjoining common femoral artery. And notice that the artery has not split. This vessel coming in here is the entrance of the greater saphenous medially. So this, knowing that this is medial, this is obviously the left leg with a normal compression. Here, in the popliteal vein, this is the normal orientation of the popliteal vein in the middle of the popliteal fossa, which is the vein, can be seen just anterior to the artery. And here we show a compression, right, nice compressible popliteal vein just superficial to the artery with the probe placed behind the knee, no thrombus seen within it, and a nice full compression with the anterior wall touching the posterior wall. So, knowing these vessels, knowing how to look for DVT, how important is it? Well, this is probably the most underdiagnosed, especially critically undiagnosed pathology in the ICU. It's something we're always wondering about. Could the patient's illness or change in clinical status be related to thromboembolic disease, in particular PE? Knowing whether there's a DVT can really help in reorder the probability that there's a PE at bay, or in play, I should say. So keeping in mind that around 10 to 100% of DVTs in the ICU are clinically unsuspected. And we all know that the patients in the ICU, they have marginal reserve, oftentimes significant cardiopulmonary problems, and suffering a PE, if it doesn't lead to arrest, certainly will lead to an acute deterioration. So how often do they happen? Well, what we know from the screening studies of ultrasound is really quite alarming, is that even in an era or in an ICU where we do excellent prophylaxis, we're finding more and more DVTs. So there's an old study that showed at 7 days, in a screening study using ultrasound of patients who came in, none of them had DVT when arrival, but after being on a mechanical ventilator for 7 days, almost 20% of them had evidence of lower extremity DVT. In a recent trial in the critical care medicine of those with sepsis who were in just prior to discharge, anywhere from 3 to 4 to 7 to 14 days, these studies were done repeat just before discharge, and almost 40% were found with DVT, and all were under excellent DVT prophylaxis. So we know they're there, and they occur despite all of our efforts with prophylaxis. Again, this is just a review of those studies. Again, anywhere from 18% at 1 week to 10% within 3 days, and to Kaplan, this article in Chest recently, which showed 37% just prior to discharge. So as we go and we start talking about these proximal lower extremity DVTs, I want to be clear for the purposes of this webinar that we're really not going to focus on calf DVT for a couple of reasons. Number one, I don't routinely look for calf DVT when I'm suspecting a PE in the ICU, largely because the calf is not really going to give me an answer. Most of the DVTs that are going to propagate or have propagated will show some remnant or existence in the proximal veins of the lower extremity. And that's usually when they will become symptomatic, is that they have to extend proximally first. So only about 8% of calf DVTs will eventually go on to BE. They will become proximal first. So when I have a question, I look proximally. A second reason why we don't look at calf DVT is even under highly trained operators and sonographers, the accuracy of ultrasound for calf DVT is quite poor. The anatomy is challenging, and identifying exactly where a clot is with the small veins and the tributaries can be quite difficult. So for that reason, we're going to avoid discussing or focusing on calf DVT, largely because it's not within our practice. So we're going to be talking about ultrasound today, but realize that over time, many different modalities have been used. Maybe some of you out there who have been doing this for a long time can remember contrast venography, where we put in needles and we'd shoot contrast distally, trying to look for any interruption in flow on imaging. There was even fibrinogen uptake scanning, plethysmography, where they were looking for delayed emptying of blood, electrical resistance changes, and then even sometimes we take patients to a CAT scanner and we look at the veins. The large reason, I would say the primary and almost sole modality that we use for DVT nowadays is really ultrasound, where you can directly image these superficial vessels and you can compress them, right? And so the lack of compressibility is the cardinal feature of a DVT, and that's largely what we use, all the others being impractical with suboptimal sensitivity and specificity, and they've largely been disbanded. So how long have we been using ultrasound? Well, we've been using it for a while, but more and more as the technology improved, right? We've moved away from A mode, now we're using 2D ultrasonography. So we really removed those other modalities just because it was so easy to use and actually very accurate, especially in the outpatient arena. It showed near perfect accuracy in symptomatic DVT. There's a few different modalities within ultrasound that we use to try to locate a thrombus. But in general, what I'm going to talk about today is largely compression ultrasound, just using 2D imaging. And as you can see, the emergency medicine and critical care practitioners over the last 2 decades have really started to use it more and more. I'll say the emergency medicine physicians use it more to get rapid answers so that they can triage their patients, whether their patients need admission, follow-up, or can be discharged immediately from the ER, whereas our utility for doing it in the ICU is variable. Sometimes we see asymmetric swelling, especially of upper extremities that have catheters, sometimes of lower extremities, and then other times we're trying to reorder the probability that someone could or will have a PE in different pathologic states. So it's a very common indication for us to try to answer clinical questions at the bedside. So how do we image vascular structures? As many of you know, we use the linear transducer, right, which is a high frequency probe or modality that can really image very clearly the superficial vessels, right? So here on the left, we have a transverse view, right? So it's perpendicular to the vein. So we see the entire borders of the vein here. And in this image, you can see just at the saphenofemoral junction, this is the saphenous vein, we see a large occlusive thrombus. The adjacent artery, which is already split here, right, shows no thrombus in it and is only deformed slightly under pressure. And so here we have an example of a thrombus, and this is the same thrombus in longitudinal view, which is not how we image. Sometimes we will image it this way for the extent once we've already identified or diagnosed it in transverse view, but we largely avoid it for diagnosis, largely for reasons because when you're trying to deliver pressure over the vein in longitudinal fashion, sometimes the pressure can be directed next to the vein or you can slip off of the vein, and so sometimes you can mistakenly conclude that something is compressible or not. And so we tend to avoid that. We only do that for, again, gauging the extent of structures. As I mentioned earlier, the foundation of the field was really by Lensing in 1989, which showed, again, near perfect accuracy with contrast venography. But keeping in mind, that was within outpatient setting. And also note that the compression technique was only at 2 sites. They really did it in the proximal venous confluences, which was the common femoral vein, down to the superficial femoral vein, as well as the popliteal fossa, and they did static analysis with a Valsalva effect on distension. So they really just looked at it and they asked the patient to do a Valsalva maneuver and they tried to see whether it distended on Valsalva. And what they found there was really, like I said, near perfect accuracy with full agreement between 2 sonographers. And based on that study, that was largely the new modality which has been used ever since. You'll see a lot of different terms in explaining how we look for DVT, things like duplex and triplex. Again, I'm not going to necessarily define them, but just keep in mind that although we're advocating compression ultrasound with B mode, or really what we call nowadays 2D imaging, there are other ways to identify abnormalities in flow that is suggestive of thrombus. So sometimes you can use Doppler spectral analysis, which is really looking at the pattern of velocity changes within the vein, and abnormalities within that can suggest the possibility of thrombosis, or it can rule it out. And same thing with color. If you don't see color flow throughout the vein, either through a squeeze or augmentation maneuver, it may suggest the existence of thrombus. And I'll go over the literature on whether those are needed in a moment. So this is an example of a 2D compression with ultrasound, right? Just using a grayscale here. You can see the contours of the vein. You can see how it fully compresses with the anterior wall and the posterior wall meeting, taking away any possibility that thrombus exists at this site. Again, to rule out thrombus, you would have to compress at multiple sections to ensure that you've interrogated the most important parts of the vein. But here at this site, there's no thrombus. This would be an example of using color Doppler. So here in transverse view, you can see the pulsatile flow of the artery, and here the slow, almost respirophasic view of the venous flow. And you can see that the entire vein fills with color flow. And what some sonographers have used is they've squeezed the leg, looked for complete presence of flow in the vein, and if they see an area where they can't detect flow, it may suggest the possibility of a thrombus, but I'll tell you that would be a non-specific finding. Others are, again, looking for velocity changes using spectral Doppler in the vein. Again, I'm not going to spend a lot of time on that, but just to introduce the other modalities. So are these other modalities necessary? Well, the answer is no, and that's been looked at multiple times, not only in the outpatient, but as well as the emergency room, as well as the ICU, in that really if you didn't diagnose the thrombus on 2D compression studies, adding color really didn't pick up any more or make you doubt what you had found. Blivus in 2000 in Academics Emergency Medicine, he found the same thing. They did augmentation maneuvers, and they found that about almost 20% of the time that patients had a DVT, the augmentation maneuver did not suggest that there was one there, and then also they were finding poor augmentation in a little over 10% of patients who did not have a thrombus. And so the only thing they found was that color Doppler decreased indeterminate diagnoses. In general, it's used to identify veins, but not really to identify thrombus. So in poor resolution images where you're not sure where the vein is or whether you're compressing exactly, you can use color Doppler to try to improve the identification of the vein. The other question that some people ask is not only, whether you have to use those other modalities, whether you have to examine the calf, which I've already addressed, but should we be doing it as clinicians? And I'll tell you, we're here having a webinar today. The answer can only be yes, and I'll tell you why in a second. And largely because it's so practical, and I'm going to go over the literature, that we can actually do it quite well, especially in the ICU. The utility of doing it ourselves is really almost incalculable in many institutions. Again, if you're at an institution that can have immediate response from the sonography or radiology or vascular department in providing a sonographer who can do this study within minutes, well then maybe the utility of learning this won't be so high. Well, I'll tell you, in most institutions that I've worked with and in my experience, nobody can be as fast as me taking an ultrasound machine to the bedside, examining the vein, and making my own decision and applying it to the clinical situation that I'm dealing with. I can also repeat it as often as necessary as things change, whereas ordering and reordering from some of our ancillary colleagues can be a challenge. So, why do I do it myself? Well, largely I took on this skill because of our colleagues in emergency medicine. They showed repeatedly in a number of studies that with focused training, doctors, emergency medicine physicians could achieve high accuracy. So in this Blivus study in 2000 that I mentioned before, physicians who were experienced in ultrasound, they did about 2 hours of didactics and 3 hours of hands-on training, and they interrogated 103 patients who they suspected of having DVT. Here again they did a 2-site compression, which is to say the proximal femoral region, as well as color augmentation, and then they did a duplex, compared it to a duplex done by the vascular laboratory. Now in these 103 patients, where they compared their exams, which is limited, with a full exam done by the vascular laboratory, 30% of the patients had DVT. The emergency medicine doctors, they had one false positive, and they also had one true positive. So although it wasn't a perfect match, I would say that it was largely accurate, and that true positive was very important, that it was negative. So the vascular lab missed it, but the ED picked it up, and we've seen that in a number of other studies as well. And so it just again shows that with focused trained physicians in the emergency room, they can accurately perform these studies in symptomatic patients. Jang also showed this. In emergency medicine, 100% sensitivity and 92% specificity, and that's in a population of 72 patients. Here, the training was a 1-hour PowerPoint lecture, as well as a general introductory course to ultrasound as part of the residency training. Here, this study got a lot of attention because it sort of pushed the envelope as to what you can accomplish with focused training. This one makes me a little nervous in that the training provided to these ED physicians was only 10 minutes. But oddly, with 10 minutes of training, they achieved 100% accuracy in these patients. This was 100 patients, and they got every single study correct when they compared it with the Department of Radiology studies. Although I think this is a remarkable result, and it shows that this is probably a very easily acquired skill, I would still be measured and say I think you need more training than 10 minutes. I'm glad that they were able to achieve that, but it's not something that I would recommend. This is one on hospital inpatients. Again, I can go through a number of these studies, really just to support all of you out there who are asking yourselves whether you can do it, whether you should do it. I'll tell you again, in the number of times that it's been looked at, not only emergency medicine, in the hospital, but here, a study that I did in the ICU, we showed that we could all be quite accurate. In fact, equal accuracy. Again, in this study, we had one false positive, as well as a number of true positives that were missed by our colleagues, but that we found. And so the accuracy was overall equal here. And it's showed up recently in the critical care medicine guidelines for the appropriate use of bedside ultrasound. That recommendation that the appropriate use would be to exclude or to diagnose proximal deep venous thrombosis was largely based on that study. And so I'm pretty proud of that result. And again, I think it supports our approach. So beyond the fact that we can do it, that we should do it, and that these are high incidence pathologies in the ICU. The other question, which I sort of partially answered as I reviewed some of the literature, is do we need to scan every 1 to 2 centimeters all the way from the common femoral vein down to the popliteal vein? And the answer is that we don't. You saw that from some of the early studies, is that every time they've compared sort of an abbreviated 2-site compression versus a complete exam, even with Doppler, no additional DVTs were found. In Bernardi from 2008, he did a randomized controlled trial comparing this, and they found no difference in DVT protection. Now, in detection. One thing that you should note is that these were only symptomatic outpatients, and that's a little bit different than the ICU. So I would also put an asterisk on this, is that there is other literature to suggest that sometimes there are DVT that are isolated to the superficial femoral vein, or what we now call the femoral vein, which is below the common femoral vein. Sometimes you can get some that are isolated to there. So if you do a 2-site exam, you may miss those. But I think for clinical purposes in the ICU, if you're really wondering about whether one propagated or whether one is causing symptoms, so if you're doing it in a symptomatic patient, I think the 2-site is sufficient. But if you're wondering if someone has DVT and they otherwise not showing any symptoms, probably a more thorough exam would be indicated. But I would start with the 2-region exam. So here I make a little joke that the Kory protocol would be in symptomatic patients, I would do a 2-region exam. But if they don't, then you can go further and scan more of the extent of the femoral vein if no clot is found. So let's sort of summarize what I've gone over, because I haven't even gone over how to do it or how you should do it, but I did want to support the field and really get you understanding that this is a very well supported and highly indicated application of ultrasound in the ICU. So number one, right, DVTs are out there, they're occurring, they're happening all the time, and they're causing a lot of illness, and this is happening despite very good anticoagulation or prophylaxis. Also keep in mind that ultrasound is the primary modality. It's highly accurate, especially in symptomatic patients, and that you don't need to do any of the fancier modalities. That compression modality alone with 2D is sufficient to be highly accurate, and also that you don't need to do thorough, compressing the entire extent of all the lower extremity veins. A 2-region exam is sufficient, or what some people call a 2-site exam will be enough. And then lastly is that we can do it. You do not need to be an expert ultrasonographer with years or even months of training and experience in order to achieve high accuracy. I would say in all of the webinars that you've seen or will see, or in the other application of ultrasound by point-of-care sonographers, I would say this is probably the one with the steepest learning curve, and one that you can achieve the highest accuracy with rather focused training. And that can occur in a number of locales, not only emergency medicine, but the hospital, but as well as the ICU. So let's sort of change gears, and let's get down to the nitty-gritty, as we say, and let's talk about how to perform a compression study. So for me, using the P's, first is get your equipment, prepare them. Position is very important. Know how to hold and position your transducer. We're going to go over the anatomy again, not only using the anatomical sort of cartoon, but as well as learning how the different branches look on ultrasound, and then know how to apply pressure, right? Recording image, you can do it a number of ways. Split screen is not the only one, but we'll go over it. So transducer, as I mentioned before, we use a linear array transducer. At a higher frequency, it allows for very good resolution for superficial structures, which is what all of our vessels that we're interested in are, right? They're superficial, and we want to really have high resolution to identify any of the echoes within the veins to identify thrombus. This would be a classic example of a good position. Here you see the leg slightly externally rotated with, notice where the operator is standing. They're standing distal to the site of interrogation with the screen, they're proximal to the site of interrogation. Their hand is on the area to be examined, and the screen is distal facing them, so they don't have to turn around backwards, they don't have to cock their head, they can look straight on, and they can follow the orientation much easier, right? And here you can't tell from this image, but the orientation marker is pointing to the patient's right, and on the screen it would be the upper left, right? Now, how do we do the anatomy? So notice that at the inguinal ligament, where we start all of our exams, things look like box 1 up here in the corner. So here you have, usually on ultrasound, you'll see this common femoral vein right next to the common femoral artery, largely and sometimes the same size. As you go down a little bit more distally to site 2, that is where you can start seeing the greater saphenous vein come in medially. As you go down further, there's oftentimes the appearance of a lateral perforator vein, that's 3. And then sort of the 4th compression is where, if you're lucky, you can see this deep femoral vein sort of bud off posteriorly to the common femoral vein, right? And after that point, we call it either the superficial femoral vein or the femoral vein. I know that's a little confusing. I'm trying to really avoid using the terms superficial femoral vein because it's a rather poor name for it, because it's not superficial, it's deep, and it's an important one to know whether there's a thrombus. After we do that sort of upper confluence, here where these branches, where the greater saphenous, the lateral perforator, and the deep femoral come in, that region, once you've compressed through that region, we then switch and we go down to the popliteal here at number 5. And we place the transducer behind the knee. So let's go through the anatomy. Know where these vessels split. I think this is the most important thing. You should practice this at the bedside. So here I am with the transducer, and I'm starting at the inguinal ligament, and I'm sliding down, and I'm ending right where the greater saphenous is. So this is a looping clip. This is the greater saphenous. So inguinal ligament coming down. Here's the greater saphenous. The other thing you should note is at the beginning of the clip, which is right now, that's the artery. Notice how the artery split. And you'll see this sort of what we sometimes call a Mickey Mouse ears, which is this is the superficial femoral artery, this is the deep femoral artery. So by the time you see the greater saphenous come in here, the artery has already split. And that's very common that you're going to see 2 arteries in your view with 1 vein. Okay, so that's the upper confluence here. So this is the common femoral vein at the inguinal ligament down to where the greater saphenous inserts medially. Again, if you don't know this at home, this is a right leg, right? Because the greater saphenous is always medial and the arteries are lateral. So this is the right leg, again, greater saphenous vein. Now, same leg. This is a looping clip, and we're going to start at the greater saphenous. So there's a greater saphenous. As we come down, that's a lateral perforator. As we keep going, this is the deep femoral. So very similar to that cartoon that I showed you, except this is the right leg. So again, watch carefully. This is a looping clip. We started here at the greater saphenous common femoral vein junction. There's a greater saphenous, lateral perforator, deep femoral. Throughout this looping clip, notice what's happening with the arteries. Right? So let's wait for this to start again. Superficial femoral artery, deep femoral artery, superficial, deep. Right? So this is where the deep femoral artery is. So you should really keep an eye on the artery throughout so that you don't confuse it with a vein. The other thing you should notice about this little anatomy lesson on ultrasound is at no point did we compress. But I am advocating that you understand what all the vessels are. Again, so just to summarize, I don't think you can go over this enough when you're teaching the anatomy, but again, greater saphenous, lateral perforator, deep femoral, okay? If I were to scan beyond this point of the deep femoral, this vein would now be called the femoral vein, right? So this is the deep femoral, common femoral vein junction, but if I were to go distally, it would just be the femoral vein, which I sometimes will compress distally if I'm particularly interested in the presence of a thrombus in a patient who's asymptomatic. In rare cases, you can find a thrombus distal to these branch points, but largely for clinical practice, most clinicians are compressing only through these sites. So how do you compress? In general, I look before I compress. A lot of times you can identify thrombus just looking at it, but in some patients, especially obese patients or in patients for whom the ultrasound has poor resolution, you will need to compress to really see how the anterior and posterior wall approach each other. Remember, you want to see if the lumen is obliterated under pressure. If you cannot see the lumen anymore, and the anterior and posterior wall meet, that's how you rule out thrombus. When you don't see that, that's when you have to suspect thrombus. And a lot of times you can see it directly. And you should mark where it is, and that way you can even follow it along on your daily exams. So here, this is an example of the common femoral vein of the right leg, right? The artery is lateral, and here under pressure with this linear transducer, can you see the anterior and the posterior wall approach each other? No, you cannot, and that's because there's echogenic material, thrombus, filled in the vein, and this is consistent with a deep vein thrombosis. I would also add that this is unmistakable. This is really a very clear example of it, which it often is in the case of deep vein thrombosis, because again, the vein is so easily imaged in most patients. It's full of blood, which is a fluid, which is ultrasound's friend. When you see soft or echogenic material within the vein, it becomes easily identifiable. So here on this example, I'm sort of showing you a normal on the left side of the screen with a DVT on the right side of the screen. Again, this image here, this is the saphenous coming in immediately, right? So this is a left leg. The artery is out here. So this on this left leg here, I'm showing you normal compression. Watch, right? The two walls meet, obliterates anything. Here, when you try to do that, what happens? Nothing but echogenic material filling the vein. Okay, so here DVT, here normal compression. So when you do the popliteal vein, again, we use a transverse orientation across and perpendicular to the route of the vein. And here you have to avoid excess pressure, because remember, if you bend the leg and you apply the transducer behind the leg, sometimes in order to create an image, you use a lot of pressure. And when you do that, you can obliterate the vein. And if you're looking for the vein, it can be very confusing. So use light pressure when you're looking in the popliteal fossa, right? So this would be how you would do it. Notice how here the operator is holding up the leg and using light pressure so to keep this vein open. Again, if you're scanning back here and you have a heavy hand and you use pressure, sort of jammed up behind the knee, when you're looking for this vein and this artery, you may not see it because this will be compressed. But here, using proper technique, you can see the normal orientation, which is the vein is superficial to the artery when using this approach. And here, using compression, you can see the two walls meet and the artery does not get deformed. So again, you're ruling out DVT here in the popliteal fossa. Some of the things that you'll come across, which I've had some of my trainees get confused by, is a lymph node, right? So a lymph node can appear circular. It has echogenic characteristics within that sort of very well bordered circle, and it can appear as a DVT. How should you know that how can you rule this out as a potential DVT? Well, in general, you can't follow this. So as you move your transducer, either proximally or distally along this lymph node, it will disappear, as opposed to veins or vessels that you can follow in sort of tubular longitudinal fashion. So this is pretty easy once you're aware of it to rule it out, but it can catch your eye and it can look like a DVT to the sort of novice practitioner. Right, and then how you document the sort of the old school way, and the way sort of our radiology or vascular colleagues was, they'll split the screen, and in general by convention they'll have an uncompressed image on the left with a compressed image on the right. Here you can see the lumen, here you don't, and so you can conclude that there's no thrombus. An easier way, and the way that I advocate, is I tend to save clips, right? And I begin the clip just at the beginning of my compression. I apply force. I show that the lumen is obliterated and that there's nothing within it, and that's how I document. So one last point I would make on that is the amount of pressure you should use should not be so high as to deform the artery. And the reason why is, in some early clots that are somewhat soft and gelatinous, you can compress them if you use a lot of pressure. So I try to use somewhat light, a little bit more rapid pressure than you're seeing in this example, just to see the two walls bounce off of each other. Again, more chronic DVTs that appear rather highly echogenic will be much more unmistakable. But again, some of the early hypoechoic gelatinous clots, if you press really slow and hard, sometimes you might conclude that there's not a thrombus there. So to summarize a lot of the points that I made, again, how prevalent is DVT in the ICU? Highly prevalent. You got to watch out for it. This is an easy way on physical exam to look out for it. If I haven't mentioned it already, physical exam is miserable for diagnosis of DVT, and that's long been recognized in medicine. Well, now that we have ultrasound as the tool, it's excellent because it is the main diagnostic tool. It's what we always use. And it's shown to be quite accurate. The other thing is we can do it with high accuracy, but it really requires some of the things that I've talked about already, which is a knowledge of venous anatomy as well as compression techniques, how to apply the pressure, how to identify the anatomy, and where to look, right? And so you really want to look at those regions with those tributaries. And so to learn, you can go over those clips in this webinar to really get a sense of what those normal branches are of the greater saphenous, the lateral perforator, as well as the deep femoral, and then what the normal popliteal vein is. And I'll tell you, with practice, you should feel quite comfortable and be able to readily either rule out the presence of or identify the existence of deep venous thrombosis in your patients. And I think it will really help in further testing and or management in various clinical situations. So with that, I'd like to thank Sonosite for inviting me to talk to you all about using ultrasound for the diagnosis of low extremity deep venous thrombosis, and I hope you all learned something. Again, thank you.